For 23 years, a 49-year-old woman managed the daily, exhausting reality of systemic lupus erythematosus. That long-term baseline recently shifted. She developed severe ankle swelling that peaked in the evenings, accompanied by feet that felt warm and red. Soon, she began waking up with a severely hoarse voice. Then the situation turned critical. Within a single month, her daily urine output fell to roughly half its normal volume. Beyond the physical pain, the patient reported profound emotional exhaustion and a steady decline in her energy levels. When a basic biological function drops off so abruptly, the 23-year history of management transitions into a state of immediate medical urgency. In modern medicine, the severity of a lupus flare-up is typically tracked through specific laboratory markers, measures like creatinine levels, tracking eGFR metrics, or urine protein reports. But when lab reports are unavailable or inconclusive, the focus on data can leave a patient's immediate pain unaddressed. Seeking relief for her daily symptoms, the patient pivoted to traditional Chinese medicine, looking for a way to address her physical distress directly. This approach suggests that focusing exclusively on a disease's name can sometimes obscure the actual lived experience of the person suffering from it. Traditional Chinese medicine views the body as a single ecosystem. Diagnosis involves assessing the movement of fluids, temperature, and how clusters of symptoms interact. Under this lens, her low urine output, hot feet, and hoarseness were not separate issues. They were seen as a unified disturbance centered in the lower jiao, the lower section of the torso's internal system. This specific imbalance was disrupting her kidney system and was interpreted as a pressure radiating upward toward the heart vessel system. The treatment principle was to warm what was abnormally cold and cool what was excessively hot until a state of balance was restored. By treating the illness as a systemic imbalance rather than a series of isolated mechanical failures, practitioners can apply non-invasive interventions to the whole body. The chosen intervention was external herbal pouch therapy. Herbs were selected for their thermal properties, but the treatment required no needles and no ingestion of the herbs. The therapy involved two distinct placements, a kidney deficiency pouch over the navel and an emotional balance pouch on the right upper abdomen. By day 4, her hoarseness improved. By day 6, urine output nearly normalized and ankle swelling faded. At the 2-week mark, her energy and bowel function had improved, though she still experienced intermittent chest discomfort, a symptom that continued to require traditional medical vigilance. These results indicate that targeted external therapies can correlate with rapid and measurable changes in internal systemic function. After continuing the navel pouch for a second course, the patient reached a 50-day milestone. Her urine output was fully restored, the redness on her feet vanished, and her overall mood had improved. It is important to note that we do not have before and after laboratory data to confirm changes in her renal markers or autoimmune activity. However, the absence of laboratory confirmation does not diminish the specific physical recovery documented by the patient. This case highlights the concept of patient-centered clinical recovery. This philosophy measures success not just by suppressing biological markers, but by restoring vitality, daily comfort, and the ability to function. While future laboratory studies are needed to evaluate how these external treatments interact with autoimmune activity, they are secondary to the patient's immediate experience of relief. For a woman who spent 2 decades in a cycle of chronic illness, the restoration of her daily function represents a meaningful clinical outcome, putting the focus back on quality of life.